your patients know what presbyopia is?
There are people who are afraid of the press.
Have you talked to your patients about multifocal contact lenses?
I've heard the bifocal, but not multifocal.
Exactly, not multifocal.
Do you need help with your multifocal strategy? Learn more at the conclusion of this episode.
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with MicroMycel, the only supplement with the exclusive patent on all 3 macular carotenoids and MicroMycel technology.
With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MySight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you. Welcome back to part 2 of my interview with Dr. George Dallam. In part 2, Dr. Dallam discusses breathing techniques for runners and how proper breathing affects heart and brain function. If you're new here and you like our interviews, press like, subscribe, share, and hit the bell. Also, please leave comments. Be sure to watch our full-length documentary, Open Your Eyes, on Amazon Prime, Apple TV, iTunes, Google Play, and YouTube movies and shows. You know, it's interesting, we talked about nitric oxide and how nitric oxide causes pulmonary surfactant to help you breathe better. So how that's important. Now, talk to me about VO2 max. There are certain integrative physicians that look at VO2 max as correlated with longevity. Tell me about VO2 max and how nasal breathing could help it.
So Patrick has kind of gone down a pathway where he positions breathing nasally as equivalent to altitude training. That's one of the places that we differ a little bit. Mm-hmm. It is the case that when you're not accustomed to breathing nasally, particularly if you're trained, right? So let's say you're a runner and, you know, the vast majority, probably 99% of runners, they breathe orally predominantly, that when you initially begin to try to breathe nasally, you won't be able to create an adequate amount of ventilation because you're not used to using your diaphragm effectively. You're used to breathing more from the upper chest. Still, there's diaphragmatic activation, but that dominant sort of upper chest breathing approach, is favored when you breathe orally and try to run. We could go into why that happens. And so when you initially attempt to breathe nasally, you can't produce enough ventilation, but you do adapt, right? So over time, your diaphragm becomes accustomed to working a little harder, and you increase how much ventilation you can create. So initially, you're in a state of what we call hypoventilation, right? Literally not just experiencing, differences in CO2 in your blood, but also not ventilating enough. And so at that point, you'll get an arterial saturation or desaturation, right? You'll see the oxygen in your blood will drop a bit. And so, that's the basic stimulus that causes the body to produce more red blood cells. The problem is, and I come from an altitude background. Part of the model I used as an elite coach was what's called a high-low model. I was one of the first national team coaches to do that in Colorado Springs, along with the cycling coaches, where we used oxygen so you could train at something equivalent to sea level, but you lived at higher altitude in Colorado Springs or even higher. And so the net effect of living high but training low is that we got the best effect overall in performance. That's a whole topic in and of itself. And so in doing that, and really a huge amount of research evolved out of the 80s around that technique around the world. One of the conclusions that we eventually came to, and you could attribute this to Ben Levine, Randy Wilbur, they're the preeminent scientists studying this phenomenon, was that to really get an effect from altitude in terms of causing desaturation, to stimulate your body to produce more EPO, to then have a higher red blood cell mass, you need like a 24-hour exposure, which is why you have to go to live there. Even like, sleeping in tents doesn't produce the same effect because it's simply not an adequate exposure. So the idea that if I desaturate for a little bit of time and that's going to be equivalent to altitude training, it's just not accurate, right? That's not remotely accurate. However, when I start to do that, when I start to exercise and try to breathe nasally, and I'm willing to tolerate a high level of discomfort and actually desaturate, my body will start adapting, and my diaphragmatic action will train, just like my muscles train to swim or to run. Our respiratory muscles train as well. And very quickly, you won't desaturate anymore, right? Over 3, 4, 5, 6 weeks, we'll get better diaphragmatic trained state. Our respiration, our ventilation capacity will improve nasally, and we won't actually be hypoventilating at that point. So, but it's not really necessary to go through that difficulty. And I'm not even an advocate that you do that. What I suggest is a more intelligent approach, and this is based primarily on my experience and a bunch of other people I've worked with who went through this adaptive process, is to just find the first level at which you start to feel a little discomfort. So let's talk about why you feel that discomfort, right? If I'm used to breathing orally and I'm used to a really high ventilatory rate, what that does is help me to remove CO2 really efficiently. So that gets complicated. It has to do with the fact that CO2 diffuses across the lung much more quickly and efficiently than oxygen does. So when we breathe really rapidly and shallowly, we never limit CO2 coming out. We just get more CO2 coming out, and we get hypocapnic, right? Our CO2 levels start to drop a little bit. And so, we get really used to that, right? Because CO2 is the primary driver of what we call ventilatory drive, and also your sensation of, am I breathing enough, right? What we call air hunger, or dyspnea, sometimes physicians will use that term. Do I sense that I'm getting enough air? So unfortunately, one of the it's not a downside, it's an upside, but when I go to a nasal breathing process, I can't produce that ventilation as quickly. I have to breathe more slowly because I'm drawing this air through all the filtration apparatus. So respiratory rates go down, and that starts to favor O2 going in, but it doesn't favor CO2 coming out. So now CO2 starts to build in the blood, right? We get higher levels of this. We get a little bit hypercapnic relative to our previous state. And that starts signaling the brain that you need to breathe more. So the interesting thing is, it's like every other signaler in the body. If it becomes homeostatic, right? If it becomes the normal, our receptors, they simply re-regulate around that or down-regulate. They don't respond as much. So that sensation, it starts going away very quickly. I've started a new study just at the end of last semester where we're going through the full adaptive process. We have the first subject in there. He's already telling me how much, he's already increased the speed he can run at nasally without feeling discomfort tremendously. It's only been like 4 or 5 weeks, right? Probably within 12 to 16 weeks, he'll be back to running at his fastest paces, breathing nasally, no discomfort different than before, because we rapidly re-regulate around this new normal in terms of the amount of CO2 in our blood.
I think I think a lot of people think CO2 is bad, from the old physiology books, where there was no good thing about CO2, but actually there's a lot of good things about CO2, right? Regulates the blood pH,
yes,
and respiratory drive. But continue, I just wanted to make that comment about that. We need a homeostatic balance of CO2 in the body. It's not necessarily bad.
No, you're exactly right. And I could talk a bit about that. I did want to make this point. If we start more gradually, right, if we find that first level where there's a little, and this is what we're doing with our subjects in our adaptive study that we're starting right now. If we go a little bit more slowly and just find that level where we have just a little discomfort and stay below that, then that CO2 down-regulation response starts to happen, or we give more time for our diaphragm to start adapting. It's kind of like, don't go in and start lifting with the most amount of weight that you can move. Start out with something that's a little more than what you did before. And then as you adapt to that, as it gets easier, then progressively move up. Really, the way training works, that's all we're doing is training our respiratory system. We should apply the same principles when we train ourselves to breathe nasally. And if we do that, it doesn't have to be an uncomfortable process. It does require you to slow a little bit at first, and then allow your body to regain that speed as your CO2 tolerance gets better, so you don't register that as unusual, and that your diaphragmatic function starts to improve, and you can improve how much air you can move nasally. As that happens, you'll regain your ability to run at a normal speed in a way that's more comfortable. So this is particularly relevant to the vast majority of people who listen to what I'm talking about are already running. They're already well trained. They already breathe orally, but maybe they've had some problem and they're thinking, maybe I should breathe nasally. When you do this with a person who's just beginning exercise, if we just start from the frame of reference that we want to do all of our exercise breathing nasally, it's seamless, right? They just limit their exercise by what they can support in terms of their nasal breathing, and then they adapt seamlessly. I had the experience maybe a year after I had adapted myself to have to take over our cross country program. We had a coach who left, and then I sort of covered it for a year until we got another coach. And I had two girls who said, should we be breathing through our nose? They were non-runners who were going to run for me. This is a collegiate program. I had to actually build it out of my classes. And I said, yeah. So they did. And they never once asked me again anything about it. They just adapted to the running as their breathing adapted to the running, right? So where we have a problem is the person who's already like highly fit in running and did that breathing orally, they have to go back down to a little slower pace, find that push, that level of effort that they can do nasally, and then slowly rebuild that as their ventilatory respiratory adaptation matches the adaptation of their skeletal muscles, or their propulsive muscles, I should say, because respiratory muscles are also skeletal, so that they get those two things matched. It doesn't take that long. I've seen people do this in 6 weeks and reach like race level, and I've seen people take as much as myself. It took me about 6 months because I was not doing it the right way. I would only do a little bit, and then I'd go right back to how I was normally breathing, and then slowly introduce that. If you slow yourself down, you can adapt relatively quickly, and then be, within probably 12 weeks, maybe something a little longer, be back to where you were before. So
I think when people start learning to breathe nasally, they have to remember that their diaphragm expands when they're breathing in through their nose. So
yes.
most people, when they breathe, their stomach is going in.
Right.
And it's going the wrong way. And
so that's a little bit interesting. What's commonly taught, first of all, a lot of people are still trying to teach you to breathe diaphragmically, but not considering that just happens automatically when you breathe nasally. You don't actually have to teach diaphragmic breathing, you have to breathe nasally. However, the idea that the stomach pooches out is actually a bit inaccurate, right? So when we breathe nasally, it's not like, especially at high ventilatory rates, like when we run, it's not like we stop using the upper body musculature. We just more dominantly use the lower body musculature, and the abdominal muscles can contract and relax. But we don't have to deliberately pooch our muscles out. Probably a better way to think about it is to kind of expand that whole lower chamber. If you're going to like use, sometimes when we're trying to teach people to do this, we might have them put their hands on the lower portion of their abdomen and focus on that expanding rather than the belly going forward. So what happens when we breathe orally is we tend to lock those muscles down, right? We sort of hold the abdomen in a state of contraction and then get all the movement occurring up here. So we don't really have to pooch our stomach out. We just have to think about, as the diaphragm flattens and opens it up, it expands in a 360 degree way.
So learning to do this by putting a book on your belly, you wouldn't recommend it?
I don't think that's a bad idea. I think it allows you to concentrate on the fact that you're breathing lower. But I would argue this, you don't actually have to teach this. What you need to do is adapt to breathing nasally, and then it happens pretty much automatically. Right?
Now let's go back to VO2 max, because we didn't cover that. Tell what VO2 max is and why that's an advantage to improve that.
So in the field that I work in, what's sometimes called exercise physiology, sometimes sports science, et cetera, kind of the holy grail of that was in the about 40s or 50s, when people who were at that time just physiologists, right? But what we call biology professors, physiologists, they started realizing that the heart was very trainable, and that when you train the heart, you prevented cardiovascular disease, you reduced the incidence of heart attack, and you increase the ability to actually move oxygen. Somewhere in the 30s or 40s, I believe, and I've lost track of the first scientists who created this methodology, but we actually figured out a way to measure the amount of oxygen that you could consume. And then our whole field has been kind of based on that as a holy grail, meaning that, the higher the level of VO2 that you could produce, the higher the amount of oxygen that your body could consume, the more work you could do, the more successful you'd be athletically, but also the more healthy you would be. And so, that's a little misleading and a little more complicated than that. VO2 max really isn't a measure of athletic performance. The measure of athletic performance is the work you can do. So it's coincident to that, right? Meaning that people who can do high levels of work, they inevitably have high levels of VO2 consumption, right? But
And they're getting more oxygen into their tissues the higher the VO2 max. Is that correct?
Well, it gets a little complicated. This is the complicated part about athletic performance per se. So when I can do more work, if I require a really high VO2 to do that, you'd suggest I'm inefficient. Why is that a problem? Well, if I'm inefficient, right, if I need more oxygen, the fact that I can consume more oxygen isn't what's important. It's the fact that it requires me to consume more oxygen to get the same work done. So in fact, the best performers typically don't have the highest VO2 maxes. They have very high ones, but they're performing higher levels of work at slightly lower levels of VO2 max. The original example, Derek Clayton, who held the world record in the marathon for a long, long time at 2:08, I believe. He only had a VO2 max that was lower than mine, right? It was in the 60s, but he was very efficient. He could produce that high rate of running at a much lower VO2. He was still up there in the category of people who are high performers, but he was better than everybody else because he was actually more efficient. So that efficiency probably has a lot to do with the idea of how much breathing I have to do, because that's essentially how I get oxygen to the lung, which allows me to get oxygen to the muscle. It has to do with how I move too. That's another complicated topic. But if I have to breathe more to produce that oxygenation, that breathing requires energy, because the respiratory muscles are no different than the muscles in my legs or my shoulders or upper body. When they work harder, they require oxygen and energy, right? They produce energy. So that means some of my energy is getting devoted just to breathing. In the athlete who generally has a little lower VO2 max to that same work level or even a higher work level, they also generally don't have to breathe as much. Less of their energy goes to breathing, more of it goes to the work that they're doing. So one of the really interesting things that we've sort of discovered about this idea of adapting to nasal breathing is that it automatically reduces how much breathing you have to do, right? When you get where you can produce oxygenation breathing nasally, you've reduced the amount of ventilation, the work of breathing you're doing by about 25%. And so right away, you become more economic, and that's where it's potentially a thing to improve your performance. We don't think that simply adapting to breathing nasally improves your VO2 max. If anything, what it does is get you to do the work that you can do at a lower VO2. You become more economic, right? That's a terminology we use in physiology when we can't study efficiency directly, when we're simply saying you can do work at a lower oxygen cost, which is a thing we can measure. So we saw that in our study, right? The people we tested were more economic when they did peak work breathing nasally than they were when they did their peak work breathing orally. So we think that will, translate, meaning that like the subjects in my current study, we think that not only will they get back to doing the same level of work at their VO2 max when they breathe nasally, that they may get to a slightly higher level of work or achieve that level of work at a lower actual VO2 max. So it's kind of exactly the opposite of how a lot of people have perceived this, that because I'm not getting enough air, I feel like I'm not getting enough air, that must be a stimulus to make my VO2 higher. That's not what we're suggesting at all. It's kind of the opposite of that. What we're doing is allowing ourselves to adapt to a way of breathing that's so much more efficient that we don't have to breathe as much once we accustom our body to breathing that way.
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
And when we breathe nasally, we sleep better.
Yes.
And we get more coronary blood flow. Can you speak to those two things?
So let's talk about the sleep thing first. And so here I have to, remind that I'm not a physician, right? But in my experience, a primary reason why people develop sleep apnea is because when we sleep, we tend to side sleep. But occasionally, because of discomfort, mattress, maybe you've got musculoskeletal stuff, we have to change our position. So, I can say from my own experience, that means sometimes I end up on my back. So when we end up on our backs, just the gravity of the situation, the mechanics, our jaw tends to open and we start adopting an oral breathing pattern, and then we can go into these apneic kinds of episodes. Again, I'm not a physician, but I would speculate, so I'm going to use that word speculate, that a large amount of apnea is simply because we end up breathing orally because we inevitably end up on our back for a portion of our sleeping time. And so that means that we go into this less effective way of breathing. That's very problematic, and we get these apneic episodes. So the second piece of what you were talking about, why is it that oral breathing is problematic in terms of getting blood into our heart and into our brain? So that goes back to that complicated idea about the efficiency of diffusion of CO2 and O2 and how we breathe. So to keep that as simple as possible, when we ventilate at a really high rate, what we call relative hyperventilation, that always favors CO2 coming out. So it doesn't really actually favor O2 going in either, but it definitely favors CO2 coming out, which means the amount of CO2 we're producing doesn't accumulate as much in the blood because it's being removed so much more efficiently at the lung. So that creates what we call hypocapnia, right? That we have a low CO2 level. So why is that so important? Well, one of the primary vasodilators or things that can be in the blood that cause the blood vessels to expand and allow blood to flow more easily is CO2, right? We've long known this, right? At rest, going back 50, 60 years, we've understood that when people go into panic attacks and hyperventilate, open their mouth, sometimes they get so hypocapnic that they vasoconstrict the blood vessels in their heart, and then they have a heart attack at the time, right? They might even arrest at the time from the anxiety attack because of that mechanism. So this idea is probably relevant during exercise because particularly once we exercise at higher levels of intensity, for the physiologist out there, maybe past our anaerobic threshold or second ventilatory threshold, there's what's called a hyperpnea or relative hyperventilation that always occurs to deal with the increasing acidity. But what we're probably also doing is maybe creating some relative vasoconstriction in our heart and our brain, because then we're dropping our blood CO2 levels at those levels of intensity where we're hyperventilating particularly. And so when we breathe nasally, the opposite happens because we breathe more slowly. We simply can't take breaths as quickly. That tends to favor O2 going in and doesn't favor CO2 coming out. So we tend to build a higher level of CO2 in our blood, which has the effect both cerebrally and myocardially of creating better blood flow, vasodilating a bit. This has been speculative because it was all based on resting studies until this last year. So a group from Baylor published a paper looking at this directly during exercise. Now, they haven't published their full paper yet. They've only published the abstract. But from the abstract, it appears they worked with people who weren't even adapted to nasal breathing and compared them at the same relative intensity, which meant that the work intensity that they were doing breathing nasally was probably lower than orally because they were not yet potentially adapted to this. But in spite of that, they actually showed that during nasal breathing, cerebral blood flow was improved in the nasal condition compared to the oral condition, in spite of the fact that their muscles were very likely getting the same oxygenation and doing the same work. How that works is a little complicated too, but so why is that so useful? Well, because that idea of greater circulating blood applies equally to the cerebral circulation as the myocardial circulation. We could speculate that the same thing's probably happening in the heart, right? The heart is always struggling to get adequate blood flow through the coronary arteries during exercise because we just don't have enough blood. And so when we exercise, we really push that to the limit. So anything that compromises that creates some ischemia. And so ischemia is the understood mechanism for how we damage our heart, right? There are potentially mechanical effects, but they're almost always blows that, that's not really relevant, right, in this condition. So one of the things we've actually come to understand in maybe the last 10 to 15 years is that people like me who have exercised at a high level for a very long period of time, they have higher rates of atrial fibrillation and higher rates of myocardial scarring, and with no mechanism, right? It's simply, wow, these people have hearts that are damaged compared to less fit people who are not exercising. yet mortality is not necessarily increased, right? We're not necessarily dying at higher rates. In fact, we're probably, the best evidence suggests we're probably dying at lower rates than average people. But still, that's like troubling, right? What, you know, you don't want that. Particularly, you don't want the fibrillation or the what's the word I'm looking for here? The sorry, I'm 65.
Is the most common
arrhythmia. You don't want arrhythmias to evolve. You don't want that situation where your heart has patchy fibrosis, so that the normal flow of electron through the heart gets disrupted. Right. Atrial fib is just the garden variety arrhythmia that's seen most, but probably other arrhythmias evolve out of that. So hypothetically, we could suggest that I wonder if this has to do with how we choose to breathe, right? I wonder if simply the idea that we have chosen to breathe orally and then maybe potentially vasoconstrict or compromise blood flow, particularly at higher work intensities, might be how we're creating this ongoing ischemic condition that explains why these athletes are getting this scarring. And that maybe if we in fact change our breathing pattern and can demonstrate better blood flow at the same work levels, that we might avoid that problem. So that's speculative right now, but what's improved a lot is we've seen already, even when you're not adapted to nasal breathing, that you improve blood flows cerebrally. It's very likely that that's also improving blood flow into the myocardium, but no one has looked at that yet.
I mean, you talked about hyperventilation, and I just want to bring up a point that if you hyperventilate too long, can make the pH of your blood go up too high. And that could
so pH going high, meaning hydrogen ion dropping, exactly, right?
That could be dangerous. So, you know, one of the problems with being having a panic attack, hyperventilating.
It's getting too alkaline, which, you know, again, homeostasis, right?
Yeah.
So that's an idea that's worth talking a bit about as well. Homeostasis is not only what's optimum, it's also what's accustomed, right? Meaning like my homeostasis for CO2 might turn out to be low because I breathe through my mouth a lot, right? It isn't necessarily a bad thing if I readjust that homeostasis to be slightly higher by breathing nasally. And in fact, there's potentially a lot of positive around that. One of the papers that came out from this same group that did the study of cerebral blood flow is a theoretical review about the idea that being slightly hypercapnic has huge numbers of benefits for us. That probably one of the modern health problems is that we're slightly hypocapnic, that we breathe through our mouth too much, both in exercise and in everyday life. And that if we readjust our homeostasis to being slightly hypercapnic by breathing nasally all the time, even during exercise, there's a lot of potential benefits. You know, for instance,
when he says hypercapnia, he means increased carbon dioxide in your blood.
Yeah, exactly. A slightly higher level, not a really high level. You know, one of the things that happens in people who can't breathe, like people with COPD, where their diffusion capacity has now been inhibited, is that they get very hypercapnic. And clearly that's problematic. That's not what I'm suggesting. I'm talking about a slightly more hypercapnic environment. So the author in the paper, he speculated particularly around cerebral blood flow and the relationship that might have to the development of Alzheimer's and other cognitive disorders. You know, one of the things we understand about that is people seem to be at less risk of that. The fitter they are, the more exercise they do, the more blood flow they can get cerebrally, because blood flow is essentially the clearing mechanism for the proteins that might actually be damaging our brain over time. And so if we're not regularly getting good cerebral blood flow, you know, we suspect that Alzheimer's and other cognitive disorders might progress more rapidly. And we see this in people who are fitter. They have lower rates of those kinds of diseases. We also see improvements in people who become fitter as they begin to have cognitive development problems. If they get into a more aerobically trained kind of exercise programs, their progressions are slower. So that relationship of cerebral blood flow is important. Exercise in general will increase that because it's increasing circulation in general, but we could argue that nasally breathing during exercise will make that effect even more valuable. Speculative at this point.
I think one of the points about mouth breathing, and you talked about the filter that's in the nose. So somebody that's smoking, that smoke is going right to the lungs.
Yes.
There's no filter there.
That's exactly right. So one of the things we know in a limited way, because it's very difficult to study the filtration of things that are known to be carcinogenic or damaging. You know, I'm also a former IRB chair. We don't let you do that, right? You can't go out and say, hey, we want you to smoke this way and that way and see what the effect is, because we already know that smoking is damaging. So the amount of research supporting this is not huge, but there are a few studies that have actually looked at the ability of the nasal passage during exercise to better filter various substances, not only particulate matter, but also some gases, right? In particular, one gas has been studied that's a very common pollutant, and clearly nasal breathing helps to reduce our absorption of that to the lung. The nasal passage does a pretty good job as long as the particulate matter is large enough. In very small, I want to say it's around 5 micron size particles or lower, it doesn't do as good a job. But clearly, at least we have the basis to think, hey, this is going to filter better. And then when we're dealing with situations like we deal with now, out in Colorado, what we deal with all the time is smoke in the air because we have forest fires all the time, all year round now. This idea that you'll actually filter that more successfully breathing nasally is also a hugely important idea. So when we start breathing in these carcinogens and or simple particulate matter, even if it isn't carcinogenic, we create this inflammation in the lung. And you could argue that's the basis for developing COPD, asthma, et cetera, over time. So again, if we reduce our exposure to those things by breathing nasally, potentially what we're doing is reducing the rate at which those things occur. You're probably aware of this as a physician. Maybe 15 years ago, we would say that 99% of emphysema was caused by smoking. Now it's more like 90%. And the other 10% is speculated to evolve even in non-smokers because of pollution, right? That's what the best science suggests. And so, our carry along with us protection against that when we go out and exercise at higher ventilatory rates is to breathe nasally to try to do a better job at filtering those bits of particulate matter that stimulate this problem.
Speaking about pollution and allergies, how about the whole concept of EIB?
Yes.
And can you talk about that? That's something that you've studied quite a bit.
So if you were to look at the number
explain
of
what
papers,
it is. And
if
explain
you
what
look
it
at the number of review papers written around EIB, it's probably nearly 20, right, over the last 20 years. Because what happens in people who ventilate more during exercise is that they start to do damage to the lung, and then that results in them bronchoconstricting as kind of a protective response.
So it stands for exercise-induced bronchoconstriction.
Yes, let's go back to that. I probably jumped ahead there. It used to be, when I first developed EIB, it was actually referred to as exercise-induced asthma. Most people understand what asthma is. You can't breathe. And so mechanistically, your bronchi constrict, right? So in my day, physicians just thought that asthma was a thing that evolved in people and that exercise was a trigger for it. What we now understand is that in people who don't otherwise have asthma, who don't get bronchoconstriction from things like anxiety or allergies, et cetera, under the conditions of exercise, they sometimes develop an asthmatic response. So we stopped calling it asthma and started just calling it what it is, bronchoconstriction induced by exercise. So that's where the EIB label comes from. So, the approach to that has always been, well, let's give them a drug that counteracts
corticosteroids.
Right, exactly.
And then
counteracts that bronchoconstriction. Of course, you know this as a physician. Drugs, like every other thing, have change. Once we administer them regularly, change in their receptor response. We downregulate around them. So over time, bronchodilators stop working as well.
And especially for me as an eye doctor, if you're using it all the time, increases your risk of cataracts and glaucoma. So I just thought I'd just throw that in there.
Absolutely. I'm just not an advocate of a pharmacological model when it's not absolutely necessary. And, I would argue it's rarely actually necessary. That runs oppositionally to modern medicine, but that's just how I view it. And so there's a problem with treating it that way. It's not very successful over time. So going back into the late 70s and early 80s, there were some physicians working with asthmatics who got really interested in the nasal breathing topic during exercise. And actually 3 studies were published, all creating conditions to try to compare people who had regular asthma, not athletes with EIB, people who had regular asthma, to see if breathing nasally during exercise would reduce their bronchoconstriction. And all 3 of those studies supported that, right? That you could essentially eliminate or largely reduce the bronchoconstriction response, even in a well-established asthmatic, simply by doing the work nasally, right? And so we've also seen this. One of our studies, which I'm not ever allowed to say who the subject is, but you can probably figure out who it is. this person had EIB, but had also adapted to breathing nasally. And we were able to demonstrate that, in the nasal breathing condition going to max, that they wouldn't experience that drop in their respiratory performance, or what's called FEV1. But when they would breathe orally, they would still experience that same EIB response, meaning it didn't go away. It just doesn't happen when you're breathing nasally, right? So we would suggest that that's the most obvious way that nasal breathing will benefit us, because the presence of EIB, in any other situation, we would call it epidemic, right? If I think maybe 25% of us got COVID and we called that a pandemic, right? Which of course it was a huge thing. Somewhere between 20% of just college athletes, and as much as I've seen reported 70% of cross-country skiers in certain subgroups of elite athletes, typically we'll talk about 50%, somewhere between a quarter and a half of athletes who ventilate as part of their process at a high rate develop EIB, right? They create this problem in themselves. So that means it's essentially an epidemic, but because it's something that they can continue to perform with, particularly with bronchodilators, we don't think about it in that context. But my personal experience is that people who develop pretty pronounced EIB at the elite level, they inevitably quit. They'll get on bronchodilators for a while. That will carry them along, but eventually it just becomes too cumbersome for them because they can't perform at the same level anymore, and they stop doing it. Right? They leave the sport.
And the exercise-induced bronchial constriction is worse in the cold and in indoor arenas where it's very dry. Isn't that correct?
Well, so let's talk about what we're coming to now, which is to really connect the idea that it's the breathing itself that's causing this. So why would that be? Why would simply going out and exercising hard, cause you to create a bronchoconstrictive response? So, almost universally, and we only have one study that ever looked at this, and it put the rate of people breathing orally at about 99% during high level, during like a big 10K, 99% of people were breathing through their mouths. Universally, athletes breathe through their mouths when they're training hard, right? And so when we breathe through our mouth, because we're not actually humidifying the air, and we're also not reducing the temperature of the air, that air hits the lung in the condition that we're breathing it in. You can actually sense this. Like today, it was in the 20s when I went out to run. When I'm breathing through my nose, I feel cold here in my sinuses. But when I breathe through my mouth, I feel that cold in my chest because that cold air is penetrating through my chest. So the cold is incidental. It's probably mainly the humidification of the air that's the huge problem, because our alveoli, simply to work, have to be in a highly humid environment. The analogy I use with my students is to say, what do you think would happen if you had this wet tissue and you hit it with a hairdryer, right? Very dry air, it's going to damage that tissue. So what we know happens is that when we breathe this dry air, and particularly that associates commonly with cold air, we actually start to damage the structures of the lung. And the result of that is we start coughing a lot, right? Because coughing is our main mechanism to try to clear this. If we keep doing that in a repeated way, then we create this inflammatory state in the lung. And this inflammatory state is the basis for which all those other lung problems eventually emerge, including lung cancer, other forms of COPD, EIB. So we could go through the detail of all the regulation that causes the bronchoconstriction. The way I like to explain it is it's a protective response. Once we start creating an inflamed lung by breathing this way, our nervous system sort of figures out we need to bronchoconstrict, so you can't keep doing this, right? You can't ventilate as much air. So that bronchoconstrictive response, it emerges out of that way of breathing, which is why we see it at increasingly higher rates as people are ventilating at high levels more and more. And then, of course, if we add in the perturbation of the environment, right? If we add air that's more likely to be damaging, like colder, drier air, like air that has, say, chloramines around swimming pools that are poorly regulated, then we see even higher rates of EIB occurring. So we know it's this combination of both the fact that you're breathing orally and that you might be breathing at high ventilatory rates with air that's more damaging to the tissue when it hits the lung without being conditioned. And we also know that basically it goes away at any level that you can breathe nasally, right? You almost don't have to go through a rehabilitative process. You just have to start breathing nasally and you stop having that bronchoconstrictive response. And then you just have to adapt yourself back to doing higher levels of work. And then the problem is gone, essentially. And that's, in my experience, which is not only in myself, but in a number of other people who I encountered, students of mine, particularly in athletes I coach, who had very well-developed EIB, but completely ameliorated that problem by then just adapting to a nasal breathing approach. There is a complication increasingly in young women, to some degree in men, but more commonly in young women. There's another expression of this problem of damaging our lung where our bronchi don't necessarily constrict, but where our pharyngeal effect occurs, where our vocal cords actually flex in a way that starts to block our breathing. That isn't really resolved by breathing nasally, but very likely it would be prevented by breathing nasally. You resolve that by using breathing exercises that teach you to relax those muscles again. So you can't just expect that to go away by breathing nasally. You really need to go through the process. We have a guy in Denver here who's really good at this. Go through the process of learning this way of breathing that allows the vocal cords to relax, but it's likely not going to occur. It's still likely an effect of actually damaging your lung because we're seeing that occurring in the same people, right? In people who are breathing at high rates. I don't know if there's any great explanation yet why that seems to occur more in females than males. It does seem to occur at a much higher rate in young females, particularly like cross-country runners, et cetera.
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with MicroMycel, the only supplement with the exclusive patent on all 3 macular carotenoids and MicroMycel technology.
Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.
OIE Broadcasting is the emerging leader in social media.
We use scientific entertainment to drive more patients into your office.
Visit oiebroadcasting.com and sign up today.